Good morning. It's a pleasure to see you all. That's a nice turnout. Thank you for spending some time with Dave Delano, my colleague, and me as we share with you a little bit about the prior authorization journey that we're undertaking in Massachusetts. In Massachusetts, we're kind of proud of doing everything first. Sometimes that involves putting the wrong foot forward, which we have done on a number of occasions, and sometimes it involves putting the right foot forward. So we're going to talk about our experiment and our evolution as an organization around the automation of prior authorization and other use cases where FHIR, interoperability, and automation can really advance healthcare and the use of healthcare information for a variety of purposes, not the least of which include health equity, cost effectiveness, and of course, clinical quality. Joining me today is my colleague, Dave Delano. Dave, are you here? Can you introduce yourself?
I'm here, Denny. I can see you. I don't know if you can see me. But
I can hear you loud and clear.
Okay. All right.
All right, let's see. Now, is this something? Oh, I can control this. Excellent. Thank you. And there's a slide advancer here. Is this also for use? Okay, I thought today what we would do is talk a little bit first about the context for what we're going to talk about today. How do we get to doing this FHIR implementation, this prototype that we're going to share with you today? Well, I'll spend maybe 5 minutes talking about that. And then I want Dave to take it over from there and talk about what we actually are doing and have done with respect to the project we undertook to implement prior authorization with one health plan, Blue Cross Blue Shield of Massachusetts, one provider, the New England Baptist Hospital, a specialty orthopedic hospital, and one technology services vendor, Olive, which had been chosen by New England Baptist as their essentially prior authorization in a box solution for them. So then we're going to spend the bulk of the time, Dave, talking about what we actually have accomplished, what we did. And then we're going to take a step and share with you a little bit about where we're going in the future with respect to automation at a much larger scale in Massachusetts overall. And we'll, at least as I've letterboxed it, we have 10 minutes left for Q&A. So in terms of background and context, 2 years ago, as the Massachusetts eHealth Collaborative, an organization that was originally managed by Mickey Tripathi, with which Dave Delano and another colleague of ours, Kathy Tournas, our Director of Finance and Administration, worked for Mickey at MHEC. And when MHEC wound down, MHDC assumed the responsibility and the management contract to support what's called the New England Health Exchange Network, or NEHEN, which has been around for a number of years, several decades, and which is a community-governed health information exchange using EDI, predominantly for administrative exchange. When MHEC was winding down, Mickey was moving to the Office of the National Coordinator. We applied for a grant to support an initiative that would carry on the spirit of the Mass eHealth Collaborative and show how networks or communities of not-for-profit organizations were advancing health IT in some meaningful way in Massachusetts. So I sat down with Dave, with our Director of Technology, Innovation, and Policy, Janice Karen, who many of you know, and with Kathy, whom I mentioned earlier, our Director of Finance, and we said, what do we want to write a grant for? There's an opportunity for us to get funding, for us to support this. And Dave said, what about EPA with FHIR DaVinci? And we all went, great, what a great idea. We jumped on it. We thought, this is fantastic. Of course, we did that without really giving due consideration to exactly what we were applying for, but we submitted a proposal and we won. We were among 6 organizations that won the proposal. And so we started off working with the 4 organizations that I put in that little graphic in the bottom right: Olive, New England Baptist, Blue Cross Blue Shield of Massachusetts, and the Massachusetts Health Data Consortium. We came together to undertake a version of prior authorization implementation focused on the very first implementation guide, which is coverage requirements discovery. And that basically, as Heidi And Kirk showed and demonstrated earlier, answers the fundamental question, is a prior authorization required for this service? Yes or no? And as Heidi and Kirk showed, the number of prior auths that are submitted that do not need to be submitted is a very high percentage. We discovered, as a result of this work, to be around 50%, but we're seeing it be even higher because there's kind of a satisficing dynamic at play where providers are just throwing everything against the PA wall because it's too difficult to discriminate the rules across different health plans. So they start doing it for everything. We thought, let's focus on coverage requirements discovery, that first phase. And with that, I'm going to turn it over to my colleague, Dave Delano, and he's going to share with you what we have accomplished and what we have done with this project.
Sure, great. Thanks, Denny, and thanks everybody for joining in today. It looks like this is a great session. I wish I was in Chicago, but I'm not. So hope everybody's having a good time. As Denny pointed out, the goal was not to do the full CRD, DTR, PAS workflow within the DaVinci project scope within the IG. It was really to just stand up a CRD service that was intent on using the existing infrastructure between all of infrastructure, essentially. So we wanted to leverage existing capabilities that were there, but at the same time, then move that toward a DaVinci compliant CRD service. So that was essentially the business objective around coverage requirements discovery specifically. And the idea was to prove that this could fit within a market-ready solution. So that's the idea. So we did this prototype of the DaVinci CRD use case, and we are planning to publish a paper. We haven't published the paper yet due to actually the transition of Olive, this portion of Olive's business over to Availity. So I saw some folks from Availity in the audience, and they may be interested in chiming in on this as well. But essentially now that business unit is a part of Availity, so we're going to be writing a white paper on this. But anyway, we can go to the next slide and then, whoop, too far.
Here we go. Hold on. I'll manage
Nope, one more. Yeah, there you go. So everybody's pretty familiar with this diagram. This is the DaVinci diagram. I think everybody's aware. It actually came out in previous presentations. So we're not going to go through this in excruciating detail, but we're going to point out a couple things. One, essentially, you've got, as I forget who the announcer was, but we've got providers and payers working together now. So I think that's the first thing to point out. The second thing is that there are multiple steps in the CRD workflow. So everybody says, well, CRD is the first step and it's very simple and we should just all, kind of go through that and move on. Well, CRD can actually cover a lot of ground, and we believe that's the case. And that's really where we've been focusing our attention in the Massachusetts community. But we're also focusing on how to do this across all payers and all providers. So we're trying to be as compliant with the DaVinci standards and IGs as possible, even though folks keep referring to PARDD, which is in the current federal proposed rule. The federal rule very much is supportive of the DaVinci IGs. So we're supportive of that. We think that's the way to go. We think that the CRD service will cover many of the clinical use cases that are essentially essential to get this process started. So that's where we're focusing. This points out the multiple steps. There's the appointment, essentially the appointment step where there's a CDS inquiry that goes to the payer through the appointment step. And this is really literally just one encounter. Encounter start, order select, order sign, and order dispatch are the steps in that CRD process. So that's where we've been focusing our attention. Next slide, Denny. So now this dives into a lot more detail, and apologize for this in terms of the technicality of it all, but the point of this is to show that there is a role in the center between payers and providers. The provider EPA coordinator, or essentially the coordinator, the idea being that there can be this, or should be, or not even necessarily should be, but there can be this entity in the center between payers and providers, as described both in DaVinci and as we've experienced within the NEHEN community. As Denny mentioned, NEHEN and NEHEN 3.0 is really where we're going with our next iteration of NEHEN, that there would be this central coordination role. And that role would essentially be the traffic cop between the payers and providers. So there would be authentication rules associated with developing authentication rules between payers and providers. There would be the handing off of the CDS inquiries back and forth between payers and providers. with the responses coming back through the CDS hooks or systems actions. And you can see what, at the bottom, the boxes at the bottom of this chart that show essentially what the roles of both the provider systems, the central coordinator, and payers systems would be on the right-hand side. And the idea being that for every, whether there's an EPA coordinator role in the center or not, that the payers' roles would always be the same. So those 4 steps with the payers on the right-hand side would never deviate. So they would always be the same. So that whether there's an EPA coordinator or not role in the center, the payers' roles would always be the same, and their functions would always be the same, so that they can interact with those that have an EPA coordinator and those that are going more direct. For example, like the EPIC example we were just talking about. But we are very focused on the CDS hooks set of standards with the CDS response cards coming back or systems actions coming back from the payer regarding those inquiries, and very much focused on this CRD step as the first step, understanding that the bottom, this can actually go right into DTR, PAS from this workflow, as described earlier. Example we just saw from Heidi and Kirk, they flow right into DTR with the questionnaires or additional information for those smaller pieces of their pie that they showed that require those additional pieces of information. So this is where we're focused. Next slide, Denny. So what was in scope and out of scope? So in scope, indications whether prior auth was required or not, hosting the end-to-end CRD request, hosting payer determination rules. So in this particular example, we did not have a payer, in this case Blue Cross Blue Shield of Mass, who had the ability to host their determination rules. So we said, well, we will host those determination rules for the payer. And that brings up sort of this notion of should there be or could there be a centralized support role there for multiple payers to use a common payer determination rules engine of sorts. And we're kind of leaning in that direction for the Massachusetts community, thinking that there could be or should be some sort of a shared resource there that folks could use to develop those rules and stand them up. The payer providing all with determination rules. So the rules belong to the payer determines the rules, just like we saw with the Regents example. They define their rules, they define their clinical guidelines, they use their standards for exchange or for determination of the outcomes of those PA requests. And then in this case, the determination of the request, which came from the EMR through what is called the Pathways solution. That's what the OLIVE solution is called. Essentially, it's clinical guidelines or pathways within their solution. They were taking essentially the payer rules, building that into an electronic pathway that then could make a determination from the CRD request coming through about whether a PA is required or not, and then what the additional information might be needed for making a determination. So launching and verifying the results, and then we focused on a very focused set of CPT codes. Out of scope, you can see the things on the right-hand side. We did not get into CQL or any kind of advanced questionnaire support. We did not have FHIR resources available through the EHRs to go back and query for additional clinical information. These EHRs that we were interfacing with were sort of traditional non-FHIR enabled EHRs at this point. So there's lots of opportunity there, obviously going forward with CRD to move in that direction, but we did not have that. Forms and templates, there were no forms or templates other than what were defined in the OLIVE pathway solution, and those were just essentially clinical elements defined for the pathway to make a determination and a recommendation about the outcome of a request. Bidirectional support between payer and provider EMR. I mean, we did have some of that. I'll speak to that in a minute about how that workflow worked, but essentially it was unidirectional exchange between the provider and the payer, in this case with the pathway solution in the center. And then we did not support hosting payer rules post-prototype implementation, so it was just for the purposes of the prototype. Next slide, Denny. So then this ended up being the prototype workflow that we enacted and implemented. Essentially starting on the left-hand side, we triggered the initial request that came from the EHR through a 278 transaction. So it came out of essentially a referral request, because these were primarily orthopedic, as Denny mentioned, New England Baptist Hospital is primarily an orthopedic facility. So we had 278 referral transactions being sent to specialty care for orthopedic procedures, typically is what were the trigger events for these. As I mentioned, we don't have EHRs there that are CDS enabled at this point with the triggers and the hooks to be able to launch into the traditional CRD process. So we use the pathways method, which is sort of leveraging the existing capabilities to generate the prior auth initial request in the CRD workflow for the pathways workflow within their engine. From there, that was then translated into a CDS hooks request, which then bounced up against the posted payer solution CDS engine, essentially, that would accept the CDS hooks request and then respond back with whether prior authorization was required or not within that workflow. So it's very kind of unique in the sense that we leveraged existing capabilities through the EHR integration. The pathways themselves were using clinical decision capabilities, and there is some embedded AI methods within that pathway solution, and there's some consumption of clinical data coming out of the EHRs into that pathway solution. And we were talking before about non-discrete clinical data. That was really the bulk of it, were things like office notes and prior notes from the EHRs coming through to supply the clinical data to make the determination, essentially fire the determination rules. So that was the workflow, and that's how things came back through the engine back into the pathways solution, which then would say, yes, prior auth is required, prior auth isn't required for a particular request. And then from there, the pathways solution would look at those requests and make a recommendation whether there was enough clinical indication about whether those should be essentially approved or not, given the information in that workflow. So we only supported CRD at the initial intake of this, indications of whether prior auth is required. We did through the existing EHR connectivity through the pathway solution, have the EHR integration. There was some response back, and I think it was essentially a request for referral response back. So the referral response that would come back through the 278 request process would indicate whether there was an authorization approved or not through that workflow. So that was it in a nutshell. We did actually show success in this model. We did show that essentially the CDS hooks and the CRD workflow is viable for setting up a rules engine in a production state environment like this, where other payers could leverage the same, essentially same interface or capability to do those exchanges. And we were able to demonstrate that over a number of use cases over a number of months' time. We didn't publish our results here because, as I said, we're planning to write a white paper on this and just sort of demonstrate the outcome and talk about what worked well and what the challenges were of implementing this sort of CDS CRD engine within a traditional workflow of this type. So that's where we ended up. Denny?
Thank you, Dave.
Right?
Yes, that's it. Before we get to Q&A, I just wanted to provide sort of what we've done since the completion of this prototype, which was completed just about a year ago. Over the course of the last 18 months, the Health Data Consortium has been working with the state of Massachusetts, state government, with the payer community, and with the provider community in Massachusetts, and that's both facility providers as well as dedicated physician providers and other non-acute care providers who are going to be impacted by the prior authorization revolution. And the proposed rule, when it becomes final, will push that even further. And what we've been working with the state of Massachusetts and with our community is talking about the exchange service we operate today, NEHEN, evolving from an administrative data exchange to support EDI X12 exchange between payers and providers for claim status inquiry, eligibility benefits verification, the common sort of core brick and mortar administrative transactions that are, what EDI is outstanding at doing, but combine that with the FHIR capabilities and the integration and exchange of clinical data between payers and providers to support not only prior authorization, but the emerging demand for quality measures in real time, the emerging demand for health equity data, which is difficult to capture and difficult to exchange for reasons that are not just technological. But we are approaching a point now in Massachusetts where we are pushing for a statewide mandate from the state government that all payers and providers who are affected by the CMS rule will, for both their commercial as well as their public health plans and products, use FHIR-based DaVinci prior authorization. Whether they do it with us through our NEHEN service or they do it directly is entirely up to them. But as Dave mentioned, we see a lot of benefits to having an intermediary focus on enhancing the value of the transaction, either incorporating the rules that health plans and providers agree constitute the rule set for prior authorization, the rules for quality measure exchange, the rules for equity measure exchange, but also, as Heidi and Kirk talked about, to reduce the amount of, if it's from vendor one, it looks like this. If it's from vendor two, it looks like this. If it's from vendor three, and just kind of ratcheting up that same kind of redundant complexity that we have in the process today and presenting to the end user a unified, simplified experience, focusing first on CRD and subsequently DTR and PAS. We're adherents of the original 3 implementation guides. We recognize that CMS had to talk about Part D because the FHIR implementation guides are not industry standards yet. They are in development, they are in use, but they need to be more mature for CMS to say, we want you to use that standard over there. We're taking the jump on that. Many of you know there's been a letter from the AMA, the AHA, the Blue Cross Blue Shield Association, as well as AHIP saying, what's with attachments and FHIR? We want FHIR. Well, we started with FHIR, and that's what we're committed to. But we want to meet our payer and provider customers where they are. And then we can work together with them to advance toward a more common and shared definition of how prior authorization is done in keeping with standards, in advancing real-time availability of information, and as Kirk and Heidi demonstrated, creating an experience for the end clinician and for the patient that is faster, better, simpler than the experience they have today. So we are rolling out what we call NEHEN 3.0. As I mentioned, NEHEN 3.0 is looking to fill that gap between payers and providers, getting their organizations ready to exchange data, technologically, culturally, business-wise, and the actual doing of that, which is enormously complicated, and where the benefits of collaboration and the use of a common set of tools might, for many of these organizations, be preferable to having to identify all the endpoints for their provider network, or having to onboard all of the payers that they're bringing into their network. And a lot of the tasks that go into creating a market being supported and assumed by a partner, a not-for-profit partner. And that's what we're building NEHEN 3.0 to be, so that payers and providers in Massachusetts, irrespective of the product, the plan, the clinical service offered, the electronic medical record environment that is supported, have the same experience and the same ease of the benefits, I should say, and realizing the benefits of automation. So we're very excited about that. We will be issuing an RFP at the end of this month. It's the 1st of August, so I can say this month today. And we look forward to talking with many of you as we move forward on this journey about what does this look like? How can we sort of advance a market of 6 million plus beneficiaries to this kind of automation and the benefits that it promotes? And so with that, I will turn it over to questions and ask, perhaps first we start with folks in the room, and then we can take questions from those online. Any questions from anybody? I see a hand.
Hey there, thanks so much for your presentation. I guess I'm a little alarmed, but also heartened that 2 presentations in a row have raised the concern about apps between payers looking and feeling different and being burdensome for providers. So, I mean, I'm super glad that that you're recognizing this and looking at this, but it kind of flags me that this could be a major concern, certainly from the provider side going forward. I wonder if you could talk more about that and kind of ways to overcome that, and kind of how much of a threat this is, because it sounds like the fact it's been brought up twice, 2 presentations, bam, it kind of makes me nervous. Thanks.
Dave, you want to take a crack at that?
Yeah, I'd be happy to, Denny. Yep, we share your concern. It's sort of like proliferation of the portals for whatever those were worth at some time, and they're still being used. Same kind of thing. It just moves it into an app world where it's integrated a little more with EHR. There is some data extraction there, but that is not the final answer for us. The final answer for us is integration within the EHR's native workflow. And that's why the DaVinci standards and the FHIR integration and the CVS hooks integration capabilities we were just talking about are so important. And I think Kirk maybe alluded to the ONC certification potentially for EHRs to be compliant with those EHR integration workflows is very much a reality that we're anticipating happening, if not soon, but rather sooner than later would be good. So that EHRs are able to integrate within their workflow. And there's this little thing, I don't know if you noticed it in my slide, it's called a system action, where rather than getting a pop-up back on the EHR screen, which is a CVS card pop-up that would annoy every provider, it would annoy me, I'm not even a provider, that these are popping up saying, hey, this doesn't require PA, or that does, or you need some additional clinical information, et cetera, that these system actions occur behind the scenes within the DaVinci standard, so that there could be a work list, for example, that other folks would then work on within the office workflow versus providers. So there is a deep consideration to that, and that's why the whole DaVinci IG integration is so important. And I think that's ultimately where we're all headed. Hopefully that answers your question.
We also recognize that payers and providers have placed their bets already on what systems they're going to use. And they expect these systems to sit behind FHIR gateways and servers with the necessary mapping of data in the disparate systems to the FHIR server or gateway, or the availability of data on the provider side through the electronic medical record and the FHIR APIs that are native to those electronic medical records. That's where we're going. We also recognize that, as Heidi and Kirk mentioned, and as you ask in your question, that without a unified experience, this is not the place for payers and providers to brand their experience. Because if everyone brands their own experience, they created a difficult experience for the end user. This is between firewalls, between the black boxes that are payers and providers. We need to have the most standardized native FHIR capabilities for exchange of data that we can possibly achieve. And we need to work with the Epics, the Cerners, the Meditechs, the eClinicalWorks, the Athena Healths, and others of the world, as well as with the Edifexes, the Zeomegas, the other systems that sit behind the payer's firewall, because that's where AI and innovation and improvement in response, improvement in simplification of prior authorization criteria can happen. That's where the business rules get set. But the exchange is infrastructure. It's a common infrastructure that, as an organization, we at MHDC with NEHEN want to provide that infrastructure as a service. And that way, payers and providers can focus on the experience of patients and members. They can improve patient access to their information. They can do things that really advance their business without getting bogged down or distracted by the technical complexity that goes into this, replicated for every payer and provider relationship numerous times. Other questions? Do we have questions online? No questions? I'm stunned. Well, I want to thank you all for your time, and I appreciate your joining Dave and me today, and we'll keep you posted of our progress, but we're excited about what we're doing. So thank you very much.